So hopefully what we have tried to do this morning is, with your help, which is fantastic, is generate some interesting discussion. And the discussion has mainly been, although what we were hoping to do is create some background, give him an emblem, and get to the meaty questions. But many of the questions which are asked are already related to, let me be blunt, is DNR. When do we do that? How do we stop that? So I will try to be now a bit quicker with these couple of talks, so that we can have just structuralize ourselves to move towards those questions a bit earlier. So first thing first, what we are, so hopefully, again, I think for the community, when we get together, why does it become so hard for us to communicate with those people? Either they have the illness or their family person has the illness. Again, you are fantastic communicators and you are here in that capacity as well. In my experience, if your neighbor has got cancer, you try to avoid them. You do not know what to say to them. You do not know where to get the phrases which can support them going through this difficult thing. So you start talking about maybe weather and cricket, which can be more torture for some people, especially if we are from Pakistan. But it's very hard to have that discussion to support them. And I really, in the next few minutes, I want us to look at the evidence in which a compassionate communication become part of what we do. Not just as doctor clinician, which is very important, but also as somebody who is an activist in the community. So, again, question to you. What do you think are the biggest barriers to have good communications with patients or colleagues or even to family members who are going through this? Sister.
I feel that there is a very, very fine line between caring and interfering, or whether the person wants to just dig into it for any reason, or they're actually caring. It's a very, very fine line. Sometimes some people feel that they don't want to talk about it, or if you ask something, they'll take it the other way, because a sentence can mean quite a few things. Sometimes you can't express what is inside you in a sentence, in words, and they'll take it the wrong way. So how do we approach these things?
Is the mic around another? Sorry.
Also, I think it's important how you ask the question. So if it's a closed communication, closed questions, they're not going to answer properly. But if you keep saying, how are you all the time, and like you say, you have to have a pause, but you need to open the question a bit more so that they can answer in a way that you think might help you as well.
Thank you. So one is the person A-based discussion. Second is actually the phrase of the question. There's another sister there.
I find that the biggest barrier is ignorance, not knowing about the illness that they. So when I go visit and I don't know a lot or anything about the illness that they have, then you really don't know what to ask.
Thank you. Thank you. That's a very good point, because we do not know if by asking or saying anything are we going to make it more difficult for them. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Me is Ishan Haider from Essex, resident alim at Leaders Islamic Center. Actually, when it comes to communication, it's not necessary that we have to utter some phrases from our mouth. Our behavior, handling them is more important than what we utter from our mouth.
Thank you. Yes, this is again that body language which starts before you do, and also the behavior, our history. And I've got a very strong analogy on it, which I heard from actually a patient. Okay. So let me tell you that one. So if I pick the last point, some time back, when I worked purely as, not purely, but mostly as consultant, I went to the hospital to a ward round. And during the ward round, so I was speaking to this patient and I said, okay, we'll do this A, B, C, blah, blah, and that's what will happen. I told him, I work at the hospice mainly, but I come here a couple of times a week. So I will pass on to the ward team who will do this. And he said to me something very interesting I learned from him. He said, okay, before you did that, can I ask who are you going to speak to? And I said, okay, it sounds like you have got a preference. Who is the particular person you will want me to speak to? And he, to my surprise, said the junior most doctor on the ward, who we call foundation year doctors. And I said, that's very interesting, and I will definitely go and speak to her. But could you tell me, why did you pick this person rather than the, I usually connect with a consultant, so who's the head of the team, or the ward in charge, the nurse, ward sister. Why did you pick this one up? And he said to me exactly what you just said. He said, this girl appears in this ward at 7 o'clock in the morning. She's still here till 6 late evening. She even sorts my water out, and she actually gets the food, makes sure everybody has eaten. And that consultant, he used some colorful language. He just comes and he shouts at her. How can I trust that guy? So patients and we ourselves in our lives, we make up our mind from the people, how they treat others. Rather than actually, we get all the communication skill training, I will sit like this and eye level and corresponding, not knowing that people are observing us in our real lives. And that actually is such a powerful message for me, it was. So I had decided to be nice to other people after then. But there are some basic principles about here. And the message is the last one. We must learn to listen as well as to speak. We don't learn listening. We just learn speaking. We are told what phrases to use. We are told what to say. Even if we are picking up the barriers, it's what do I say? How do I say or phrases rather than how do I listen? Which becomes the most effective part of the discussion. What is the, again, question for everyone, what is the most loved topic in the world? Everybody wants to speak about. Weather, politics, but there's a good one, which is me, I, themselves. If I start a discussion without even knowing them, who they are, do they have a family? And I again take some analogy back from my younger days. And I use this phrase a lot because I just subconsciously picked that up. If I'm getting on a train from London to Birmingham and somebody, first of all, nobody speaks in the train, do they? In England. In Pakistan, everybody just talks. But if you spoke, phrases go something like this. And I'm not saying it's right and wrong, it's just a difference of culture. So, what's your name? My name is so. The next question almost always is what? What do you do? And I come from not just Pakistan, but I come from a rural area. And it was always taught to me from my childhood, it's very rude to ask, what do you do? Because it puts the value of a person. You can ask about family, you can ask about, because everybody has a family. You can ask about where you're coming from, where you're going, before you get that confidence to say, what do you do? You don't ask that question straight away, because people put a monetary value on you by what you do. So it's rude. And I'm not saying it's right and wrong, it's a difference of values. So the communication is, what I'm trying to say, is based on how do we value them, rather than how do I value the information. Information is not important, that person is important. And in short period of time, what do we learn? Is actually we feel impulsed to pass on the information as a doctor. I need to tell them you have got cancer. I need to tell them that we need to make decisions, rather than starting to get to know them. Anybody knows this guy? Shout out the name, please. Tony. Donny. Donald Rumsfeld. Do you remember when was he famous? Iraq War. And he was brought in, if you remember, I'm sure the crowd is really heavily politically aware, and he was brought in with a specific task for his communication skills. And this is what pressured, and I'm definitely not a fan of him at all. But when I was observing, it actually gave me a very good picture that basically he lost it because of the external pressures he was under. I'm not saying that he was a nice person and he was put under the pressure. He brought it on himself, but the reality is we need to learn from what we can get wrong in our discussion. Can I get somebody to read this if they have a mic? Any volunteer? Can we read it loud, please? I need somebody. Maybe we can give to Arif Bhai the mic. And just try to make sense of what is being said.
Somebody has warned me that I will speak his words. As we know, there are known knowns. There are things we know, we also know there are known unknowns. That is to say, we know there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know.
What a load of garbage. Sorry, not you, what you said. What he said. He was asked the question, where are the weapons of mass destruction? And that was his answer. Became very famous. Like, actually, does he really know what he's talking about? When this guy is so eloquent in his language, he thought he was giving a very clever answer. The point is, the people who were listening did not understand a single word what he was trying to say. And then he was asked another one, so you will think he has learned. And then he was asked about Osama bin Laden, and I will read it myself. We do know of certain knowledge that he is either in Afghanistan or in some other country or dead. What a clever answer. Then he was asked next day, is that really what you said? And he said, well, no, I didn't. Well, I believe what I said yesterday. Well, I don't know what I said, but I know what I think, and well, I assume that's what I said. When people are, no matter how eloquent we are, if we do not judge the situation well, and honestly speaking, in this case, what I think, when you know you are lying all the time, then you basically go. So when you are trying to hide from a patient, have you come across those? So let's get a bit serious and talk about how many of us say, don't tell the patient he has got cancer. And that's when you spill all of these things. When you really want to, so-called, protect them from the information. And this is when we make a real mess of it. There are lots of examples. In the vaccine time, it came, but important thing. What are you worried about in terms of patients or their families' reactions when you are breaking bad news? What is it that can happen? Because as I said, when we are put under pressure, oh my God, I can't tell them they've got cancer because it'll be so bad for them. What are we thinking? How will they react? So psychological, what impact, please?
Yeah,
This is
so
very good.
their impact will be they will feel that, they will feel down, depressed.
Depressed.
Whatever,
Depression is one.
Yeah.
Yeah. Anything else? Shock. Crying. This is a good one. Can I ask back? Why is it bad? Crying. If somebody is crying. Our Maulanas rather here who make us cry in every majlis. And we love them for it. So it's our problem. Thank you. No, thank you. Thank you so much. So basically, we feel a bit under pressure if somebody starts crying. Now, at least let me ask you again this very quick question. And I know it's a bit sensitive because many of us would have lost our parents, for example. But if I were to ask all of us, and I'm not asking for any questions answer back, but just think of it. Can you think of one person today, right now, you cannot even imagine you will lose them at one stage? There will be somebody in everybody's life. It could be your wife, your husband, your child, and especially when you're older, your children. You will never imagine that. Because that's the worst trauma. But I tell you something else. Please help me out here. When we were little, like 10, 15 years old, how many of us imagined that one day we will lose our mother or our father? Your impression will be, I simply cannot live without them. If it happens, my whole life will be destroyed and I just stop living. Guess what? Some of us have continued living after that. My point is, we are very worried about their reaction. Could be shock, could be crying, could be depression, could be even anger. But let's look at it this way. The worst death we can think of is the person we love the most, right? And let's say it's our parents. Average age of the patient we look after, even in the community, our friend, we are talking about 70, 80 years old. Am I right? Where are their parents? Where are their uncles, their aunts, even their siblings? 1 in 5, 80 years old in this country have lost their spouse. 1 in 9 have lost somebody immediate relation like brother, younger than them. 1 in 27 have lost a child. The worst grief you can think of in the world. My point, their life has been through a lot. They're just being honest. If they are psychologically disturbed, why shouldn't they be? Why shouldn't they cry? That should not stop us being compassionate towards them. We have a duty to do that. We get anger, crying, irrational reasoning, body language changes, and all of that comes. But here is the point. If you look at these things, if I want to say something to you like I'm doing now, I thought of an idea. This is what I will come and say here to you. First step, composition. Then I found some vocabulary about it. Then I arranged it in my head and my body language. And then I just used the words. But what you just said to me, you're not worried about any of that. What you're worried about is not even them receiving message, but how do they reflect on it? That's what we are worried about. Guess, and information for you, you haven't got any control of that. You only have control on the first 4 things which you have seen in green. This is where we need to concentrate more on. That our arranging mode, our perception of an idea. And by the way, what I said, the idea does not start that day. It has started years before. What is my relationship like with that person? If you are a doctor, the way I have walked into their office, their room or clinic, or walked to their bedside, how was my body language looking? How was I arranging the chairs? How was I actually offering them water? That conversation has started. Same way as a neighbor, as a community member, our relationship has started before that. Quite often, I'm sure, like Maulana Sahab said, all of us are asked, can you come, there is a difficult situation, can you come and help talk to this person? Well, you are asking me, I've never met them. You have met them like 40 years of their lives. But the confidence is gone. And this is where they ask you for that confidence. All my job should be to bring that confidence back, for them to continue having that discussion. Again, it's not important what we say, it's how we say it becomes important. So I won't go through all of that. But we use something in communication world. So it is translated for clinical discussions, but it is valued in business sectors, is valued in political, and it is validated also in manufacturing world. So whenever you are going to have a difficult discussion, you start by setting up. Obviously, Setting up has already started, but you set up, you think of the words, you arrange it well, arrange the room well. But important thing is, you start by asking them, what do they think is happening, where they are. So when we heard that, it's very important that actually what are we going to say, and because we do not know the words, in my opinion, more important is what are they thinking they are going through. That's what I need to find out only. I can talk about other things later. And believe you me, you will think that it takes time. And like Mohammed Abbas said earlier, as clinician, my usual discussions of most sensitive topics are 10 minutes and less. Because you just set up, and by achieving their perception, you can have a good, meaningful discussion with them. These are the two important points to me. And then I invite myself in their world. And I ask the question, I'm here, how can I help the best? Rather than you said, Assistant Naseem said very rightly, we ask close questions. Make it broad as possible. We are here just to help. As community member, as your neighbor, as the person who goes to Jamaat with you. Rather than, you can do this. You need to talk to that person. You need to go there. And that makes it much simpler. Only then, if we need to knowledge, and in my opinion, this is useless anyway, because by now, they know everything anyway. As doctors and clinicians will give them time, but for us as community members, that becomes it. But this is what we are worried about. What I'm going to say to them? Well, it's not important. You need to ask yourself question, how will you listen to them? Rather than what will I say to them? And important thing is, we forget about asking the emotions. Are you feeling low? How hard is that to ask the question? And people will get angry with that, I can tell you this. You say, are you feeling low? No, I don't care. But that is a discussion on itself. And this is how we can support. And when we strategize and summarize and move forward. But we have got pitfalls. And this is what evidence tells us. This is, again, it's not clinical discussion we are talking about. I have languageized it in clinical world, but this is the evidence you get usually. Have you heard which profession is the most trusted in the country? Any idea? Sorry? Hairdressers. I don't trust. Can you not see my hair? Okay. Go to the least bar. Which profession is the least trusted in this country? Wow, everybody knows that. Politicians. Every survey they come the lowest. And just above them are? Sorry? No. Anybody else can think of? Estate agents, they are really the lawyers. So they're very, and this is the data which comes from those studies. Because they choose to misunderstand the question, because they are asking the question and then modulating according to their needs. And that's where people start losing trust in the society. Guess what? Politicians are on the television more than you and I. And that's what people see. So how should they suddenly start trusting other people? They're coming. That's why we need to practice that well. The thing is that because we all think we are good people, we believe other people should trust us. Because I'm meaning well. I am always here to help other people. I do so much community work. Why should you not trust me? Well, why should they? And this is where the whole discussion starts. They would not, just because, sorry, scholar sitting there, because you're Maulana, I'm sure everybody trusts you. But starting point is, well, they are going through such grief and difficulty, they will think everybody is coming them to teach a lesson. And this is where the problem is. So and this is why we need to improve our questions which we are doing, if we are asking. Sometimes I ask you the question back, don't they? In clinic, what do you think is the commonest question a doctor gets back? Sorry? Why me? But more than that, how long have I got? And what's the answer? Sorry? Only God knows, yeah. I don't know. And you have to be brave enough to say that. But the point is that we need to be prepared for all those questions. And the important thing is this, that all of this discussion, all of this support to each other, we need to look after ourselves when we are doing that. And have I got a minute?
Yeah.
Just one short story. My mother died in February 2014 after a long illness. And I was very, obviously, we lived together, close people, and I thought palliative care, I've come out of it so nicely and easily. And I was, I think I coped really well. 3 months, a few months down the line, I was in the hospital, and my colleague said, "Oh, Qamar, you are here. We're discharging this patient home, but your team is going to look after her in the community. Why don't you go say hello to her?" So I walked into this patient's room thinking, easy peasy. Just to say hello, hi, my name is Qamar Abbas, bye. And I walked into her room, and I think it was playing on my head, because later on I realized she wasn't actually like that. She, at that particular second, looking at her, her facial features was the same as my mother. And you were taken aback. So I had to say to her, I need a break, I'll come back in 5 minutes. So I had to go out to prepare myself to come back and speak. Of course, I looked after this patient for a few more months, and I realized there was nothing like my mother's features. But at that particular time, your mind plays. But you need to accept that. If you are not in the right frame to speak, you need to accept it. So am I the right person? Is it the right time to do that work? And this is what I hope I'm trying to put a frame so that we as community members can empathize with the people who are in that situation. Thank you.
Awesome, thank you so much. We're going to move on to advanced care planning very shortly, but we've got quite a few questions coming through the slider, so I really appreciate those. We're going to take 2 questions only through the slider, and then we do have a Q&A in about 30 minutes, so we'll go into that. But the 2 questions that came through for Maulana Saab, if that's okay. One of them is, what advice can we offer our community and patients on spiritual guidance for palliative patients and their families?
Bismillah ar-Rahman ar-Rahim. I think there is, we had a very useful and interesting presentation by Dr. Abbas, and I think there's many things that we can take from it. I would like to just add to that by saying that it's not about what you say, it's how you say it. There is a very beautiful example in the Quran where Allah subhanahu wa ta'ala, when He sent Prophet Musa and Harun to Fir'aun, He says to them, وَقُولَ لَهُ قَوْلًا لَيِّنًا, addressing both of them, that when you talk to him, layyina, I would say, proper translation would be leniently, politely. Now Fir'aun, I don't think you will ever see a Fir'aun in your life anyway, whether you're talking about anyone from the community or yet Allah subhanahu wa ta'ala. I mean, somebody who used to say, Ana Rabbukum al-Ala, I am your great Lord, against Allah. Still Allah subhanahu wa ta'ala says to Musa and Harun, be lenient to him when you talk to him. Maybe he will be guided. And so it's a very important point of, not necessarily what you say, it is how you say it. And so when we talk about people who are suffering because of illness, for us, especially the followers of the Ahlul Bayt, we have more than enough examples from the lives of the Imams, the suffering that they have gone through, and that gives us strength and courage to go through it. For example, if you're talking to any lady, the words of Zainab salawatullah alayha in the presence of Ibn Ziyad, when he says, what is your view that what Allah has done to your brother? When she says, Ma ra'aytu illa jamilan. she basically turns everything upside down for Ibn Ziyad. That whatever I've seen is beauty. You know, nobody can go through that kind of difficulty. And so I think, you know, going back to the examples that we have, that would give us more strength to go through the challenges and difficulties that we go through, inshallah.
And one more question that's come through is at what point is the soul taken from us? Is it after death, i.e. after the heart stops? And how do we justify resuscitation after the soul has left?
It's a very loaded question. Yes, we believe that, you know, death is in the control of Allah subhanahu wa ta'ala. So yes, the question would be relevant that if death has happened and the heart has stopped, then what is the point on trying to revive the patient? But again, looking at the example from Imam Musa al-Kazim alayhi salam, where he says, you know, if there is a doubt, you know, give 3 days. Maybe, you know, we are not sure the heart has stopped, but maybe his soul has not totally been taken. And so this issue of reviving, especially if there's a cure still there for that person, would be relevant. But I'm not sure whether every CPR or revival is going to work. There's no guarantees there. And so if Allah has decided to take his soul anyway, you can do whatever you want, but nothing will happen after that.
That's very comprehensive. Please, yeah.
Thank you. Just trying to put my information here as well. I think again, like Allah has said, clearly hitting the nail on the head of the nail. It is something when, so not talking about soul and the faith part of it, just responding to that, we think that what is reversible or not. As I said earlier, and maybe it was a very quick one, that then cardiac arrest is the only thing which can lead us to have a successful CPR. When you have CPR, without going into much detail, you have got 3 types of activity. That one is when your heart stops and becomes completely flat. It's called asystole. And if it is on the background of disease, the statistics are there that we do not know of the way of reversing it. Where because of the disease, not because of heart. The things which mentioned very fantastic from Imam or 7th Imam about electrocution from lightning and as well as drowning. In my days, we used to call it electromechanical dissociation. Nowadays, we call this pulseless activity. And basically, these are the things which are reversible, which medical science recognizes, and we need to do everything. So when we should not have a blanket DNA CPR for if the heart stops for any reason, do not do that. The clinical advice will still be, not Shari advice, the clinical advice will be that if the heart is stopped because of widespread motor neuron disease, for example, in which all the nerves are paralyzed and your heart is stopped, so even if you are jumping, that nerve activity is gone, so heart is not going to jump on itself. So we know the chances is 0. So if it is because of the disease which stops the heart with the evidence that is 0 activity, the 0 chances of recovery, then we should be signing those forms. Even, for example, there is something called best interest decisions in this country. If somebody has got widespread cancer, but God forbid he has a road traffic accident, which means that he is now dying because of road traffic accident on the roadside rather than cancer, we should still be resuscitating them. That will be overruled at that time. That if the clinicians believe that it is a reversible act, they should be doing it.
And often many of these are almost everything is case by case, so there's complexity for it. but I think a lot of that is highlighted. Thank you so much. We've had a really good discussion on communication skills, and we'll talk a little bit more about it a little bit later.